live streaming.
Sir, we are live on Facebook and
Yes.
YouTube as well.
Yes.
Let's
Yes.
start.
Yes.
Thank you.
Welcome, all friends. I think this is the third case we are discussing on this web platform. I'm really thankful to the team of Poland who are working behind the screen to make this presentation available to you at different places. So this is a good way to get connected with all of you when we are actually having COVID times. So I really thank Poland for supporting this activity. I'm again asking you whether my screen is visible to you. Am I audible?
Yes, sir.
Yes, sir.
And my screen is visible?
Yes, sir.
Yeah, okay. So this time, actually, I had chosen a case which we recently managed a month back, a case of acute pancreatitis. Actually, though I am presenting this case, actually my team is working with me. You must be knowing Dr. Rohan Gundre, Prashant Akulwar, Pradeep Taur, Yogesh Adkine, and we have got two now fellows who are actually doing a fellowship in critical care after their anesthesia, Dr. Mayuri Pur and Priti Bhagyavanta. So as a team, I am representing to you as a case. So let us go with the case. Actually, pancreatitis is not very uncommon to everybody of us. This case actually, as I told you, is a third case in this series. A 70-year-old male got admitted with upper abdominal pain, nausea, vomiting of 3 episodes in one day. He is old with hypertension on telmisartan. On admission, he was conscious, oriented, pulse rate of 90, BP 130/90, and he has got tenderness in the left hypochondriac region and epigastric region. So this is a clear case of acute abdomen, and we were surprising what will be the diagnosis. And one differential diagnosis was acute pancreatitis. The patient was non-alcoholic, so still the pain and probably vomiting made us to think of acute pancreatitis. So epigastric abdominal pain, what are the differential diagnosis? Acute myocardial infarction sometimes can be present as a epigastric pain. So always look for the signs of clinical signs and presentation of acute myocardial infarction. And at least ECG has to be done even if patient is complaining of epigastric pain. Acute pancreatitis is a important diagnosis with epigastric pain. Chronic pancreatitis also can present with such type of pain, peptic ulcer, gastroesophageal reflux disease, then gastritis or gastropathy, functional dyspepsia, and gastroparesis. They are slightly uncommon causes of acute pancreatitis. So most of the patients with acute pancreatitis have acute onset, persistent, severe epigastric abdominal pain. So almost 80% patient present with such type of epigastric pain. In some patient, the pain may be the pain maybe in the right upper quadrant, and rarely confined to the left side. Approximately 90% of the patients have associated with nausea and vomitings, which may persist for several hours. So epigastric pain with nausea and vomiting, one should definitely suspect acute pancreatitis. So this patient was actually admitted in a surgical department as he was got abdominal pain, and surprisingly the lab shows hemo concentration 17.3 hemoglobin, leukocytosis, low platelet, raised urea creatinine, normal electrolytes. LFTs was somewhat normal. PT-INR was quite okay, and he has got increased lipase and amylase. In addition to that, being a case of epigastric pain, vomiting, and some fever, the dengue IgM test was same, that is NS1, which was positive. His HbA1c was 6.3, so slightly on higher side. LDH was 1202. Ferritin was 1000 and procalcitonin was 1.56, and ECG was within normal limit. So this is, I think, a routine kind of blood test to advise. My sincere request, when you suspect infective pathology, initially, it is always a good approach to send a basic lab. Basic lab, what I mean is a complete blood count, liver functions, kidney function test, sugars. And as I told you, ECG is very important, though it doesn't look like in cardiac etiology on presentation. And I think dengue NS1 is also quite rational at this moment of time. But adding to it, doing LDH, ferritin, and procalcitonin probably will cause more confusion and add to the some unnecessary direction and treatment when it was really not required. Because of COVID, probably we are starting doing much more markers, biomarkers, which we never used to do before COVID. So we were not suspecting COVID in this patient, and even if patient is having COVID suspicion, doing markers on day one, I think not a very good idea. And procalcitonin, again, sometimes it was thought that it may differentiate between viral and bacterial infection, but the sensitivity of procalcitonin in diagnosing bacterial infection is quite low. It may tell you the prognostication if you do repeated procalcitonin, and it may tell you that patient is doing well with decreasing procalcitonin. So single procalcitonin may confuse you. So that's what I wanted to convey when you give a list of investigation on day one. So obviously, this lab needs to be taken into the account very seriously, whether it's a dengue or acute pancreatitis, because dengue test was positive, amyloid lipids were high, and in fact, patient was having thrombocytopenia. So there was hemoconcentration, thrombocytopenia, leukocytosis, which was slightly against diagnosis of dengue. Then lipid amyloids were raised. So whether we should go for further imaging to confirm a diagnosis of pancreatitis or not, that was a question. But to my surprise, when I searched into the case reports, there are a couple of cases which presented dengue as a presenting symptom as acute pancreatitis or dengue causing pancreatitis. So it is not uncommon, or it is not unknown that dengue fever may lead to pancreatitis. Basically, out of multiple causes of pancreatitis, one is infection, post-viral. So dengue sometimes can having direct impact on the pancreas and may lead to inflammation and may cause pancreatitis. What about this CBC, which is having all three cell lines are abnormal? One is HB 17.3, WBC was 28,000 and platelet 69,000. So hemoconcentration in secondary to dengue is well known. As well, it is also a part of acute pancreatitis. So with pancreatitis, leukocytosis and elevated hematocrit can occur. Hematocrit may go up because of the extravasation of intravascular fluid into the third space that we all know. And pancreatitis is basically an inflammatory condition. So activation of granulocyte and macrophages in acute pancreatitis results in release of number of cytokines and inflammatory mediators. So raised WBC count in patients with pancreatitis is a marker of inflammation rather than infection. Other markers like C-reactive protein, interleukins, tumor necrosis factor, this all can go rise in case of acute pancreatitis. And CRP is quite important in case of pancreatitis because it is documented that if it is above 150 at 48 hours, it is associated with severe pancreatitis. So it has bad prognosis. So what I wanted to convey with this CBC is that Hemoconstitution, though it is a part of dengue as well as acute pancreatitis because of the extravasation of fluid, the leukocytosis, which actually hints toward the inflammation of pancreas, and low platelets is possibly because of the inflammation or dengue. So something which is slightly unusual to have a dengue with a pancreatitis, such type of patient we had. And then about hemoconcentration, particularly in acute pancreatitis. It results because of the stir space losses and it causes high hematocrit and it associated with severity of pancreatitis. So hemoconcentration is an early risk factor for necrotizing pancreatitis. That is from American Journal of Gastroenterology. This patient again had a significant rise in amylase and lipase. So let us learn about amylase and lipase, which are a commonly advised test to rule out pancreatitis or to diagnose pancreatitis. Remember, if they are raised 3 times of the normal limit, then they are significant. Which test is better, amylase or lipase? Remember, amylase goes up at 6 hours and it comes to normal within 10 to 12 hours. As compared to amylase, lipase starts rising early, 4 to 8 hours, and it remains at peak at 24 hours, and it returns to normal after 8 to 14 days. So if your patient comes to you after 24 hours, and if you do amylase and it is normal, it is not a reliable test because it can be normal after 24 hours. So if you compare amylase and lipase actually start rising early and remains for a long time. So it has got better diagnostic sensitivity than amylase. It is almost 80 to 100%. And remember, in alcoholic pancreatitis, amylase may be normal or false in negative in 20% of the patient. Similarly, another cause of pancreatitis is hypertriglyceridemia. In 50% of patients with hypertriglyceridemia associated pancreatitis, the triglyceride interferes with the amylase assay. So even in triglyceride patient, amylase may be normal. So more reliable is lipase than amylase. There are multiple causes by which amylase can go up. So there is a list of causes by which hyperamylasemia is occurring: pancreatic diseases, intestinal diseases, malignancy, then renal failure, fallopian tube diseases, alcoholism, cirrhosis. All these can cause amylase. So it is not very sensitive because it can go rise in other conditions also. This patient underwent a CT scan which shows acute edematous interstitial pancreatitis with mild hepatomegaly and bilateral moderate pleural effusion with collapse of underlying lung. Remember, a bilateral effusion and some collapse of the lung is quite common in cases of pancreatitis. So my further recommendation is, or the discussion is, whether to do an ultrasound or CT scan. Remember, in our setting where we have limited facilities of doing CT scan in multiple centers, particularly in semi-urban and rural area, and ultrasound is available at bedside. So which test is more better? So in pancreatitis, acute pancreatitis, the pancreas appears diffusely enlarged and hypoechoic on abdominal ultrasound. And importantly, gallstone can be seen on ultrasound. So gallstone pancreatitis is another common cause. So you can look for gallstones, gallbladder, and edematous pancreas. Necrosis of pancreatic tissue is recognized as a lack of enhancement after intravenous contrast of the administration, and this can be only diagnosed with the CT scan. So if performed 3 or more days after the onset of abdominal pain, contrast enhanced CT scan can reliably establish the presence and extent of pancreatic necrosis and local complications like peripancreatic collection and predict the severity of the disease. So in early stage, particularly in first 3 days, the ultrasound can be a better diagnostic tool, and there is no need to rush for scan in early stages. So routine abdominal scan is not recommended in initial presentation in patient with acute pancreatitis unless there is a diagnostic uncertainty. If your ultrasound colleague is not very sure about the pancreatitis, then probably you can consider CT scan. Otherwise, CT scan with other clinical findings and enzymes, you can diagnose the pancreatitis. There is no evidence that CT scan improves the clinical outcome. Basically, a CT definitely helps in the later stage of pancreatitis where we wanted to rule out the local complications of the pancreatitis. Complete extent of pancreatic and peripancreatic necrosis may be only become clear 72 hours after the onset of acute pancreatitis. So again, I just wanted to highlight that ultrasound in initial 2-3 days is good enough to diagnose pancreatitis. So diagnosis of acute pancreatitis requires presence of 2 out of 3, a clinical presentation of persistent severe epigastric pain radiating to back, elevation of lipase or amylase 3 times or greater than upper limit of normal, and a specific characteristic findings of acute pancreatitis either on CT or MRI or ultrasound. So if out of these 3, 2 are present, consider it as acute pancreatitis. In this particular patient was non-alcoholic, triglycerides were normal, he was not taking any drugs which are causing pancreatitis, and even he was not having gallstone. So probably the left is dengue causing pancreatitis. Though dengue doesn't have any specific treatment and patient is having a severe pancreatitis because of having raised creatinine on day 1 with low platelet, it's having organ failure. So we have to focus more on pancreatitis rather than management of dengue, which is a very supportive kind of management. There are a lot of scoring systems are available to diagnose the severity of pancreatitis. This is one of the modified Marshall scoring system where you have to consider like SOPA score, respiratory rate, PO to FI2 ratio, creatinine levels, cardiovascular system like blood pressure, and then accordingly you calculate the severity. Another important scoring system is Ranson criteria. Ranson criteria is assessed at 0 hours and at 48 hours, which consider age, WBC count, blood glucose level, then and LDH and AST. At 48 hours, again hematocrit, blood urea nitrogen, serum calcium, PaO2, base deficient, fluid sequestration. So if this criteria shows 1 to 3, if there are only 3 things are positive present, less than 3 present, then it is a mild kind of pancreatitis. If it is more than 3, 4 or more, it is a severe pancreatitis. So it is very important when you treat this patient, you should know whether we are dealing with a mild kind of pancreatitis or it is a severe kind of pancreatitis. This was a treatment he was receiving before he shifted to our unit. So he was getting antibiotics, doxycycline, pantoprazole, analgesic tramadol, and IV fluids. What I wanted to highlight here about the antibiotic use, I'm going to talk on antibiotics in pancreatitis in my further talk. Doxycycline, actually when patient is having fever with thrombocytopenia, and when we're not very sure about the etiology of this febrile illness, then empirically covering doxycycline in a country like India is quite rational, and even many guidelines have suggested to add doxycycline initially when you suspect something like topical fever with the leptospira and like conditions. But routine use of doxycycline in each and every febrile patient, of course, not recommended. So during treatment of pancreatitis, the dilemmas occur because of on multiple issues like fluids, how much fluid we should give, whether we should give antibiotics or not, what is the role of nutrition, whether enteral or parenteral, or should we keep patient NBM, and how long we should keep patient NBM. Then what is the intervention patient requires? An organ support system when patient is in multiple organ failure. So we actually repeated the lab on day 2. It was quite similar. Low platelets, high, slightly decreased level of hematocrit, raise urea creatinine with potassium of 5. So it's slightly alarming with this urea creatinine and potassium that we are actually dealing with a severe kind of renal failure. Then patient was put on a NIV. He was having tachycardia. He required noradrenaline to maintain his blood pressure above 90 to 100 systolic. He was tachypneic, respiratory rate was 34. His saturation on 40% of non-invasive ventilator was 94. So there was some hypoxemia also. And ABG shows acidosis, and clearly it was a metabolic acidosis when the bicarb is 11 and lactate was 2.6. So something like lactic acidosis patient was having. So whether we should really use a non-invasive ventilator in such patients. Remember, again, I'm going to tell you when to use and when not to use non-invasive ventilator. Patient is having clearly acidosis on the blood gas. He is in shock, tachycardia. His respiratory rate is on a higher side. So such patients, particularly, and the pathology, which is not going to recover in a few hours or few days, going to take a longer time. In such patient, it is better to have elective intubation and ventilation. Remember, patient was having low platelets. If you do emergency intubation, probably at midnight or odd hours, and when a trained person to intubate is not available, he may end up in having more bleeding complication. So in such critical patients with multiple issues and multiple complications, probably organ involvement, and significantly shock, I think we should electively intubate and ventilate this patient. So we have ventilated this patient, intubated and ventilated. Fortunately, there was no bleeding after intubation, and patient could be managed with sedation analgesia. And I think in such patient, we must do rapid sequence ventilation. So we use muscle relaxants with analgesia and sedation. This patient was on the verge of dialysis. So there was a discussion in our team whether to do a dialysis or not. He was having good urine output. There is no severe acidosis. And his hyperkalemia 5.1. Actually, his ECG was not showing signs of hyperkalemia, but it improved with the medical management. So we hold it on dialysis, but we kept dialysis team ready with putting a HD catheter. So we were ready to dialyze the patient, but we were waiting. Again, there is enough evidence about early versus late dialysis critical ill patient, and even if we do late dialysis, there is no mortality benefit, mortality increase with a late dialysis. So we can definitely wait and observe the patient critically when you have a facility to monitor and do dialysis at time when patient actually requires it. So we kept a watch and we were ready with the dialysis, but we have not started dialysis. So I just wanted to discuss about the management of this patient. The most important and probably not very rigidly followed treatment of pancreatitis is fluid management. Somebody might wonder, what is there in fluid management? We all give fluids. Basically, fluid management is one of the important part of the management in every critical ill patient, and we should know how much fluid we should give in how much time and when to stop giving fluids. So it is always a dilemma at bedside. About the pancreatitis, isotonic crystallite solution should be started at 5 to 10 ml per kg per hour. In patients who are severely volume depleted, the manifestation with hypotension, tachycardia, we need to give more rapid repletion with around almost 20 ml per kg of IV fluids over 30 minutes, followed by 3 ml per kg per hour for 8 to 10 hours. So when you are giving fluids for longer hours, you need to monitor patient frequently for adequacy of fluid resuscitation. Rarely patients with hypercalcemia, which is quite common calcium in pancreatitis, if you give ringer lactate solution, it contains actually calcium. So it is contraindicated in patient with hypercalcemia. So give normal saline rather than lactated ringer. And as you all know, the colloids or starch are actually out of the ICU now because of multiple complications and increased risk of mortality because of the colloids or starch solutions. So we are using crystalloids, preferably normal saline and ringer lactate, and we have to consider hypercalcemia as a contraindication for the ringer lactate. The role of fluid resuscitation is adjusted based on the clinical assessment, hematocrit, and urea nitrogen level. Adequate replacement can be assessed by improvement in the vital signs like heart rate, then mean arterial pressure, urine output, and reduction in hematocrit. The goal is to have 35 to 45% of hematocrit and improvement in the blood urine nitrogen at 24 hours, particularly when they are high at onset. So this is very important to note the effect of fluids in various clinical parameters and urine output and urea creatinine levels in pancreatic patients. So in the initial stages, particularly in first 12 to 24 hours, acute pancreatitis fluid replacement has associated with reduction in morbidity and mortality. So it's clearly shown benefit if you give adequate fluids in first 24 hours, it reduces the mortality. Inadequate hydration can lead to hypotension and acute tubular necrosis, and that will lead to AKI and further complication. The persistent hemoconcentration at 24 hours has been associated with development of necrotizing pancreatitis, which is a kind of severe pancreatitis and have got higher mortality. So first 24 hours, I think, are very, very crucial in patients of acute pancreatitis, and we should give much adequate fluids with at least monitoring some parameters. I would rather suggest if you have a central line monitor, put a central line, at least look for changes in the central venous pressure, and of course, heart rate, urine output, blood pressure, and keep an eye on fluid replacement and see that the patient gets adequate fluids in first 24 hours. Persistent hemoconcentration has been associated with development of necrotizing pancreatitis. Necrotizing pancreatitis results in vascular leakage syndrome, leading to increased thirst space loss and worsening hypoperfusion. So, necrotizing pancreatitis with leak again causes pancreatic hypoperfusion and more damage of the pancreas. Again, when to limit the resuscitation of fluids after first 24 hours, it is important to limit the fluid after 24 hours to 48 hours. And a continuous aggressive fluid after 48 hours may not be advisable, as over vigorous fluid resuscitation is associated with increased need of intubation and increased risk of abdominal compartment syndrome. So that you have to keep in mind. After 48 hours, patient may land up in intubation or abdominal compartment syndrome. Pain control, of course, very important. Abdominal pain is often predominant symptom in patients with acute pancreatitis, should be treated with analgesic. Uncontrolled pain may contribute to hemodynamic instability, so you have to take care of it. Attention to adequate fluids should be the first priority in addressing the abdominal pain, and as hypovolemia from the vascular leak and hemoconcentration can cause ischemic pain and result in lactic acidosis. So if you give fluids, then probably your pain will also go down. Opiates are safe and effective at providing the pain control in patients with acute pancreatitis. Adequate pain control requires use of intravenous opiates, usually in the form of patient control analgesic pump. The important management strategy is use of antibiotics. So everybody knows that pancreatitis is an inflammatory condition. Inflammation is not an infection. So each and every pancreatitis particularly doesn't require antibiotic. what guidelines suggest prophylactic antibiotics are not recommended in patients with acute pancreatitis, regardless the type of pancreatitis, whether it is an interstitial necrotizing pancreatitis or severe pancreatitis. But it is prophylaxis has no role. That 20% of the patients with acute pancreatitis may develop extra pancreatic infection like bloodstream infection, pneumonia, UTI. In such patients, you may consider antibiotic use. And use of antibiotic in such patient actually reduces the mortality and improves the outcome. When the infection is suspected, antibiotics should be started while source of infection should be determined. So you should know whether you are treating a VAP or HAP or urinary tract infection. Accordingly, you can think of using rational appropriate antibiotic. However, if cultures are negative and there is no source of infection identified, antibiotics should be discontinued even in pancreatitis. Nutrition. I think the days of keeping patient NBM for long has gone in all critical ill patient. Particularly even in pancreatitis, it is a strong evidence to start feeding as early as possible. Enteral nutrition has definitely aged over the parenteral nutrition. So nutritional support is often required in patients with moderate to severe pancreatitis if they are unlikely to resume the oral intake within 5 to 7 days. Nasojejunal tube feeding is preferred over total parenteral nutrition. Oral, at the time of reinitiation of oral feeding, depends on the severity of the pancreatitis. In absence of ileus, nausea, vomiting, oral feeding can be initiated early within 24 hours as tolerated. And if pain is decreasing and inflammatory marker improving, you can definitely start giving the oral feeds. In some patients with moderately severe to severe pancreatitis, oral feeding may not be tolerated due to postprandial pain, nausea, vomiting, related gastrointestinal inflammation, then extensive compression from the fluid collection leading to gastric outlet obstruction. So because of few reasons, patient may not tolerate enteral feeding. Enteral feeding rather than parenteral feeding is recommended in patients with moderate severe pancreatitis which cannot tolerate the tube feeding. So in such cases, you can consider parenteral nutrition. Enteral feeding requires radiological or endoscopic placement of jejunal feeding tube beyond the ligament of trees. If placement of nasogastric feeding tube is not possible, nasogastric feeding should be initiated. So it's not necessary to put tube in the jejunum. Even you can give with nasogastric feeding. The use of high protein, low fat, semi-elemental feeding formulas are used because of the reduction in pancreatic digestive enzymes. Signs that the formula is not tolerated include increased abdominal pain or vomiting, bloating, and diarrhea. If patient having increased abdominal pain after feeding, has sensation like bloating and diarrhea, then probably have to differ with the oral nutrition. Enteral nutrition helps in the maintenance of intestinal barrier and prevent bacterial translocation from the gut. Avoidance of complication associated with parenteral nutrition, like it causes infection, including those of secondary venous access and bloodstream infection, they can be avoided with enteral nutrition. The parenteral nutrition should be initiated only in patients who do not tolerate enteral feeding, or if the target of enteral feeding is not achieved within first 72 hours. At the use of then you can use parenteral nutrition with enteral nutrition. That is called as partial parenteral nutrition. But it has been seen that if we use with parenteral and enteral nutrition, it is slightly harmful than without it. So the issues in the patient which we were treating was acute pancreatitis, shock, AKI, hyperkalemia, metabolic acidosis, respiratory failure, leukocytosis, and thrombocytopenia. So this patient, after 5th day of intubation, started getting fever, increased tracheal secretion which were purulent. We did an X-ray chest, and X-ray chest shows some patch So unfortunately, patient developed a ventilator-associated pneumonia. Remember, it is quite common in our ICUs to have a VAP, and we should take adequate precautions to prevent VAP. So what we did, we sent cultures of blood, endotracheal aspirate, and urinary catheter, urine from the catheter. Antibiotics were already continued as patient has increased requirement of FiO2 and PEEP. We changed the antibiotic empirically to meropenem and polymyxin because our flora in our ICU is mostly gram negative, which includes Klebsiella, then Pseudomonas and E. coli. So considering this gram negative resistant organism in our ICU, we empirically started meropenem and polymyxin to this patient. And we are actually sent all the blood pan cultures. Day 6, we recorded that his positive balance, fluid balance is 4 liters, and he was having edema all over, and that was causing problem with the weaning of the patient. So we actually decreased fluids, and we actually tried to reduce the positive balance by giving diuretics at that time. Endotracheal tube culture shows gram negative bacilli. ABJ was having metabolic acidosis with decreasing lactate, and there was we stopped giving fluids, and we're given a sort of Ditor because he was too much of the fluid overloaded. So prudent endotracheal secretion, tachypnea, negative fluid balance, X-ray chest, chest of VAP, and the culture genetic curve is a E. coli. E. coli was quite sensitive to fosfomycin in our ICU, that is 4 gram per 3 times a day. So we started with fosfomycin with meropenem and polymyxin. So in spite of that, fever continued. So we thought of other sources, and then we removed Colles catheter. We changed central line. We inserted a fresh central line. Then gradually patients started responding to all supportive care, which includes sedation, analgesia, good nutrition, adequate fluid resuscitation in initial hours. This actually made patient improve, and then we actually chosen appropriate antibiotics based on our culture cellular data, and patients started improving after day 12. And then first weaning trial was failed because of tachypnea with minimal pressure or TPs. So as his ventilator stay got prolonged, we did a percutaneous tracheostomy. He was on Norlin support for long time, abdominal distension, and we repeated the USG abdomen. That patient was personally having fever, so we just wanted to rule out any peripancreatic collection, so that we did ultrasound, and ultrasound did not show any other additional complication rather than acute pancreatitis with bilateral minimum pleural effusion. So ultrasound in between can give you idea whether patient should go for CT scan or not. So this is a impression of CT scan. Patient has got bulky pancreas, suggestive of pancreatitis. There was mild ascites, paralytic ileus, and hepatomegaly on scan. These were the reports of the patient. Again, just I wanted to highlight the lactate amylase was quite normal, normal, but lipase was on the higher side. LFTs were reasonably okay, and he was having initially improved renal function after a few days of treatment. Then ultimately, patient had a lot of problems at the time of weaning. Patient had loose motions, then abdominal distension, hyperkalemia. He has got hemoglobin was 6.9 on day 18, and hypokalemia. So we transfused the platelet considering his age and hemoglobin level. Then day 24, he remained hemodynamically stable and he was requiring minimal ventilator support. So he was given TP style. And then almost after 34 days, he recovered, weaned off from the ventilator, got decannulated, his rise tube was removed, and he was started oral feeding. And he could able to chew in spite of prolonged ventilation. He could take a good amount of oral nutrition without any problem. Diarrhea is very common in patients who are on enteral feeding and patients with pancreatitis. So we need to have a algorithm to treat the diarrhea in ICU. Particularly, most of the time, it is because of the antibiotics and drugs which we use in ICU patients. So be careful about the multiple antibiotics. They may cause pseudomembranous colitis or Clostridium difficile diarrhea. So diarrhea is important issue which we'll discuss in some other case. So patient improved initially acute pancreatitis. It was severe pancreatitis because of he was having multiple organ involvement like renal failure, coagulopathy with thrombocytopenia, and respiratory failure. He developed a ventilator pneumonia in between, and so we had to give a broad spectrum antibiotics, and then patient recovered after 34 days. He required tracheostomy. Fortunately, he did not develop major bed sores during this time, and he never had a DVT during this prolonged ICU care. The issue when I was talking about such kind of patient is his platelet count was low. When platelet count is low, whether to give heparin or not is a big question. All patients who are moderate to critically ill and particularly on ventilator, they require DVT prevention or DVT prophylaxis. So what one should do, whether to give heparin or not? So answer to this question is, patient, we can continue to give low molecular heparin, which is quite safe and proven efficacy to prevent DVT. So as long as his platelet count is more than 50,000, you can continue heparin. And if you can't give heparin because of the bleeding complications or platelet less than 50, then you can use intermittent compression device for prevention of DVT. But if there is no contraindication, then you can use both. And don't worry about giving heparin if platelet count is somewhere around more than 52 lakh. So whenever there is a bleeding, you can stop it, but no active bleeding, only thrombocytopenia of more than 50,000. I'll defer to stop heparin, and I'll continue to give heparin in this patient. So this particular case was quite straightforward, but what we learned from this case is initially pain and vomiting was suggestive of acute abdomen, but dengue positivity slightly got added the confusion of diagnosis, but dengue can lead to direct impact on the pancreas and may cause pancreatitis. That is a known fact. So patient have dengue induced pancreatitis, and the treatment of pancreatitis is particularly fluids in the first 12 to 24 hours. So adequate or more than adequate fluids are important to see that the organ perfusion and pancreatic perfusion will maintain and hematocrit will come down. The high hematocrit because of the extravasation of fluid is a risk factor for the patient with pancreatitis. In daily round, you should have some scoring system that decide whether the patient is improving or not. Then there is no role of antibiotic in mild pancreatitis and there is no role of prophylactic antibiotic in such patients. So don't give antibiotic just because you're having fever or some kind of important labs, like most of people consider WBC count as a marker of infection and they start higher antibiotic. In such patient, if patient really develops a necrotizing pancreatitis and develops a big infection in the abdomen, and we are already used broad spectrum antibiotics like carbapenem or colistin, patient will have resistance to that antibiotic, and when he really requires it, we'll not able to treat this patient with the antibiotic. So fluids, antibiotics, then nutrition, very, very important part for pancreatitis. And I think enteral nutrition scores over the parenteral nutrition, and consider parenteral nutrition only when a person or patient cannot tolerate the oral feeding. So thank you very much. I'll be happy to answer some questions. If you have any questions, please put it in chat box. Or I think I'll ask admin to actually unmute everybody so that we can have some discussion.
So we have the questions in chat box.
Yeah, the one question is that can this be considered as a sepsis-induced DIC? His other parameter except thrombocytopenia, there was no other lab which was actually tells us that patient in DIC, but it is possible that patient may have DIC. See, in pancreatitis or in dengue, the problem is of platelet production as well as destruction, but mainly it is a suppression of the platelet production, and you get a low platelets. That doesn't mean all low platelet patient has got DIC, and there was no active bleeding. So DIC is one of the differential diagnosis of infection and thrombocytopenia, but this patient particularly doesn't look like a DIC. Anybody would like to ask question directly? There is another good question. Antibiotic choice in this patient. As I told you, acute mild pancreatitis having no obvious signs of bacterial infection doesn't require antibiotic. Number two, there is no role of prophylactic antibiotic. Number three, if at all patient needs an antibiotic, where to justify which is the source we are considering as a source of bacterial infection. Is it a lung? If it is a lung, then it is a hospital acquired infection. If it is a hospital acquired infection, what are the common hospital acquired infection in particular hospital? And what is the flora of that hospital? If they are having a gram-negative flora like E. coli, Klebsiella, Pseudomonas, or Acinetobacter, then what are the sensitive pattern of that particular ICU hospital? Then accordingly you can consider empirical antibiotic. But when patient is in shock, patient is having low platelets, and so this is something like a severe pancreatitis. Even if patient is having severe pancreatitis with no signs of bacterial infection, will not start antibiotic. And if you suspect there is some collection around pancreas, like peripancreatic fluid collection, patient is having fever and signs of infection, ongoing infection, the good idea is to drain the pus from the peripancreatic area, send it for culture and sensitivity. If you think the lung is a source or urine is a source, take this appropriate sample and send it for culture sensitivity. And even Piperacin tazobactam is one of the good antibiotic having good penetration to the pancreas. And if you want to cover pancreatic necrosis and petrification with the antibiotics, I think it should be culture based, and empirically you can use carbapenems in patients with severe pancreatitis with acute necrosis, and CT is showing a collection. And till you get a report of culture sensitivity, till that time you can use a broad spectrum antibiotic like carbapenem, and then subsequently according to patient condition you can change it, or you can discontinue it or de-escalate it. Peripancreatic necrosis per se will not require antibiotic unless there is a collection of infective material or fluid. The another question is, if patient having DIC, can we consider heparin? It is a debatable role, but as I told you, even if patient is having low platelet more than 50,000, we can give heparin, and if there is no obvious bleeding, then there is no contraindication per se to the heparin, but you have to be very, very careful to monitor the patient's bleeding from any side. Patient usually is having Foley's catheter, central line, endotracheal tube. GI bleeding is very common and very possible in such patient. So keep a close watch, and if you feel that patient is high risk for bleeding, like patient is having hypertension, is already on antiplatelet, is having chronic renal failure where platelet dysfunction is obvious, in such patient you may not give heparin and use a sequential compression device or mechanical way of preventing DVT. Yes, of course. This is a good question, whether we can give nasogastric feeding. It was initially thought that jejunal feeding is better tolerated in pancreatic patient, but if patient, we cannot put jejunal tube, even nasogastric tube is good enough to start enteral feeding. Any other question? I think if there are no questions, we can conclude this case. Actually, this case I presented just because pancreatitis, though we know it is a straightforward management, I wanted to highlight the fluid management in first 24 hours. I wanted to reinforce that WBC count is not a marker of bacterial infection. I just wanted to reinforce antibiotics are not required in pancreatitis unless there is a evidence of bacterial infection, and nutrition can be started in first 24 hours. Enteral nutrition preferred over the parenteral nutrition, and even nasogastric nutrition can be given to this patient. So fluids, no antibiotics, nutrition, enteral, start early is the key for management of pancreatitis. And always look for causes of pancreatitis, and if it is removable causes like gallstone pancreatitis, you have to take the surgical step. And in severe pancreatitis with necrosis, then only we have to do a intervention like drainage of pus, and in severe cases necrosectomy. But by and large, pancreatitis has potential to have a multi-organ failure kind of condition with inflammatory response, and a critical care management is required, and surgery, role of surgery comes after 2 to 3 weeks of acute pancreatitis for dealing with the complication like pancreatic abscess, pseudocyst, and peripancreatic collection. So thank you once again for your very good response and patient listening. So from Poland side, I think you can have a concluding comments.
So yes, sir, thanks for this insightful talk of yours on the very crucial topic on the management of acute pancreatitis. And to all the participants and all the viewers, in case you might have missed the initial things or any things in this session, you can reach out to sir on his social media handles, as well as this talk is available on our YouTube channel, as well as on all our social media handles, that is Facebook and LinkedIn. So you can also, in case you might have missed, you can view the same repeat broadcast on the said portals. And thanks for your patient listening, and thanks for being there with us. And until next time, from Poland and the team, thank you. Let's meet in the next month again with some new and fresh cases. So until
Yes.
the next time, take care. Thank you.
Thank you. Thank you.